Time is to move on to our second presentation, actually, with Dr. Stacia Woodcock, who is joining. And I like to think about this segment, Stacia, as Ask the Pharmacist.
Yeah, absolutely. Just to sort of give an overview, cannabis use in the United States is rapidly increasing. Just from the early 2000s to now, we've seen a pretty rapid increase in the percentage of patients and just lay people who are utilizing cannabis, largely because of the legalization within the state programs. So a lot more people are looking to cannabis as an alternative therapy because it's becoming more available in their state. In several surveys, it shows that 81% of United States adults believe that cannabis has at least one benefit, and about 91% believe that cannabis has at least one risk. What's interesting from a medical perspective is that the one risk that people indicated was largely legal problems and addiction. So they're not looking at any sort of risk from a medical perspective, which is really interesting to consider based on sort of what we know about cannabis and the possible drug and drug disease interactions that may exist. Although there are few, there are definitely some. The other thing that's changing is the demographics of who is using cannabis. So in the early 2000s, it was largely youth who were using on the illicit market. Now it's largely adults, and that's definitely due in large part to the shift towards medical cannabis and then also the legalization of state recreational programs. So adults have more access and feel more comfortable using cannabis now as opposed to before. So the two main questions that we have is, we have growing prevalence of cannabis use, both for medical and recreational purposes, but we don't have a lot of information. So why do we not have more data on cannabis, and what data is currently available, and how is it being interpreted by practitioners and patients? And I think this is really important for researchers to understand. Sue did a great job of outlining why we don't have more data, how difficult it is to do the research that we need. But we're in a really unique position where the application has outpaced the science. So the medication is largely available, but we don't have the research to back it up. And there's not really any other incident where in the history of sort of medicine where that has occurred, where something is being widely used medicinally as cannabis without the proper research to back it up. And so that's largely what I want to focus on today, sort of where that gap is and what is happening in the real world to sort of address that gap. So I'm not going to belabor this. Sue did, Dr. Cicely, did an amazing job of sort of explaining the limitations of NIDA, how difficult it is to get approval from NIDA, and then the fact that any cannabis that's obtained through NIDA comes from the University of Mississippi. It isn't really indicative of the quality product that's going to be found currently in the medical and recreational markets in the United States. So I'm not going to go into depth. She did a great job of explaining this, the barriers to research. But despite those barriers, we do have a really rapidly increasing number of cannabis studies every year. And that's due to the clinicians who are really interested in the science and exploring more about what this plant can do for patients. And Dr. Cicely is really sort of spearheading that, which is amazing. But there's an exponential amount of research being done. What's important to understand, though, is that research is largely preclinical or observational due to these limitations. And so when we look at observational studies, they don't have the same intervention. It's just an observation. And so that means that we have association and not necessarily causation. And the standard example of that is if you look at increased sales of ice cream, you'll see an association with increased drownings. But it doesn't mean that eating ice cream causes people to drown. It's that there's a third factor, which is hot summer days, that increase the incidence of both. And so we see often this data get misinterpreted and misapplied when it's not properly interpreted and evaluated. So when we talk about additional barriers to research, and I believe Dr. Cicely talked about this a bit as well, it's challenging to placebo control cannabis because of the natural terpenes and flavonoids that do exert a medicinal effect. Getting a true placebo is challenging, so a lot of times a relative placebo is used. And then blinding is also very challenging due to the intoxicating effects of cannabis. It can make it really apparent to patients when they're receiving active medication. So blinding is a huge challenge to overcome. So when we look at additional challenges, and again, Dr. Sisley mentioned this, the current governmental source of cannabis is not really reflective of what patients are using in the real world. So that kind of means the majority of the research done with the NIDA cannabis isn't really that applicable to real life situations, because that's not the sort of product patients are using or receiving. We also have a lot of preclinical data, which is fantastic as far as looking at potential applications of future human studies. But, a lot of people take that to mean that absolutely the same effect will happen in humans, which is not necessarily the case. And so that can be challenging as far as interpreting that information properly to both clinicians and patients. There are also varying formulations. So when we look at a lot of these studies, they'll talk about milligrams of THC or milligrams of CBD, but they don't give information on the delivery mechanism. For example, if it's a tincture, is it an alcohol-based tincture, an oil-based tincture, a water-based tincture? The vehicle makes a big difference in the absorption and onset of the formulation. So the nuances of cannabis formulation are really important to be specific about. Even when it comes to different varietals of flower, the terpene and flavonoid composition has a very huge impact on patient outcomes. So it's important that any sort of research is very specific when it comes to these different formulation varietals, because it definitely has an impact on how it's going to affect patients. And it can even be something as simple as if you're doing an observational study on irritable bowel syndrome and you're using an oral capsule. Those patients are already prone to absorptive issues because they have underlying digestive abnormalities. So inhalation would actually be a better formulation to do a trial on for accurate absorption. But a lot of these nuances get lost in the science because of a lack of the deep understanding of the different formulations of cannabis and the pharmacokinetics of those formulations to know what should actually be studied for that particular patient population. And then finally, there's a lot of misinformation. When we look at the interpretation of the studies that do exist, it's largely being disseminated through very pro-cannabis lay people, websites and things like that. It's not necessarily coming from a clinical source that knows how to properly evaluate a study. And so often study results get misinterpreted, or the information gets sent out to the general public in a way that may not actually be indicative of the truth. And I think a good example of that is, everywhere on the internet, it tells you that cannabis cures cancer. We don't have good human studies to back that up. We have really great preclinical data. There's a lot of good data to suggest that it might, but you can't interpret that to make widespread claims. That's going to mislead the public and mislead practitioners as to how this research can be applied in real life scenarios. So when we look at the areas of perceived benefit, obviously there are far more than this. These are just the main things that we see patients coming into dispensaries for. And the majority of the state programs for medical cannabis include these different indications: pain, anxiety, PTSD, epilepsy, chemotherapy-induced nausea, vomiting, autoimmune disease like multiple sclerosis, neuropathies, and degenerative diseases. Cannabis is perceived as having a low rate of addiction with no apparent risk of overdose fatality, a potential role in the reduction and treatment of opioid addiction, and having mild side effects with few serious contraindications or drug interactions. And then the areas of perceived risk are increased adolescent access to cannabis within a legalized program, increased motor vehicle accidents, the development of cannabis use disorder, reduced cognitive function and long-term brain injury with prolonged use, the psychosis-like effects and paranoia, disorganized thinking associated with high doses of THC, and lung injury or cancer incidents with smokable dosage forms. And it's important to understand I'm citing these as areas of perceived benefit and areas of perceived risk, because the majority of these have some sort of association with cannabis, but not necessarily any sort of causation indication. But this is sort of how practitioners and the general public perceive the risks and benefits of cannabis, regardless of the research that we have. And so what that means is, where do practitioners turn when it comes to interpreting data and helping their patients? So the gold standard, obviously, is the National Academies of Sciences, Engineering, and Medicine 2017 report. It was a massive, comprehensive review of the clinical studies available to look and see what we have clinical evidence for and what we need more research on to really understand cannabis better. And it reached these therapeutic conclusions, which is far less than I think most clinicians would anticipate. So a lot of them are surprised when they look at this study and they see really the only conclusions, the conclusive conclusions the review could make is cannabis for the treatment of chronic pain in adults as an antiemetic for CINV and for patient-reported spasticity and multiple sclerosis, and then moderate evidence for improving short-term sleep outcomes. And I always say it's important to note that, while this seems to be the gold standard for most clinicians, epilepsy is not on the list. So the clinical trials for Epidiolex had not been completed at this time. So it just goes to show that cannabis science is advancing rapidly and changing rapidly. And so even this report, which is supposed to be the most up-to-date review, it's only 3 years old, still lacks some good progressive research that's been done since then. The report also addressed several adverse effects. I'd like to highlight the mental health because this is the one that we see a lot of clinicians fixate on, which is the association between the development of schizophrenia and other psychosis with the highest risk among the most frequent users. Also increased incidence of social anxiety disorder, suicide, completion and ideation, and a small risk for the development of depressive disorders. And this is a classic example of association, not necessarily being causation. So we don't know if these disease states predispose patients to self-medicate with cannabis, or if it's the cannabis that's sort of amplifying these underlying disease states and symptoms, or if it's simply causing them to begin with. So there's definitely a lot of misinformation around these specific results because people misinterpret an association to mean causation. So the other thing that practitioners often consider when looking at cannabis research is also just a standard drug-drug comparison. So a lot of their patients are using or trying not to use opioids, antidepressants, specifically tricyclic, that have a lot of adverse side effects, anti-epileptics, muscle relaxants, benzodiazepines. So they look at the side effects, the risk of addiction, the withdrawal, the potential harm to the patient versus cannabis with a relatively safe profile. And that's where they sort of garner whether making cannabis recommendations is a good idea for their specific patient base. And I love this chart because it shows in a really interesting way. So this is a general list of all of the qualifying conditions throughout the United States, and these are the most common. And when we apply the level of evidence that we have, you can see that the large majority of the things that practitioners are recommending cannabis for and patients are seeking treatment for have very little clinical evidence to support them. It's really only 2 or 3 of the top qualifying conditions that have any evidence supporting their use. So it's really a situation where we have practitioners completely flying blind. And they have a lot of different influence when patients come in. So the first is obviously there's a lack of research. So, doctors are used to looking at their PDR and knowing exactly what dose of what medication to prescribe for this specific diagnosis. And that's not how cannabis works. A lot of practitioners are very uncomfortable with that. They don't understand the self-titration component. They don't like patients having control of their own medication. It's very foreign to how they are comfortable practicing. And so that creates a barrier to them recommending it to patients or being willing to participate in their state programs. And then we have a significant patient-led and industry-led push towards alternative medicine treatment. So what we're actually seeing with cannabis is it's patient-led, patient-focused, They are the ones who are really pushing their doctors to provide them with recommendations. They're seeking cannabis medication. It's not the doctors who are advising it, which is sort of the opposite of how traditional medicine works. Usually you go into the doctor because you're not feeling well and you trust whatever they tell you. And it's not of the norm to say, I want to try this. And so with cannabis, we're actually seeing the opposite, where patients are really leading that push. And then it's also important to understand that the stigma still plays a significant role. A lot of what we see in the dispensaries as pharmacists, patients are afraid to talk to their doctors about cannabis. We've had patients who've been dropped from their primary care practice once they tell them that they are using medical cannabis. It's very scary and very daunting. So patients are losing their care. Their doctors are refusing to certify them and won't see them as patients anymore if they do get certified outside of the practice. Practitioners also are worried about the legal implications. They have a buffer between certifying versus prescribing that provides them with sort of the separation of the liability of using cannabis. So they're not prescribing it, they're just recommending that patients might want to try it. But it also means that a lot of practitioners take a very hands-off approach to how they then advise patients to utilize medical cannabis. And so that kind of leads to the question, well, if practitioners are so reticent to get involved, is it important to have their involvement at all? And I think the answer is, of course, yes. Not only, when it comes to an ideal situation, the practitioner is going to be educated and understand how to evaluate the patient for any drug-drug interactions or drug-disease interactions. You can also see on what patients are using cannabis for in non-medicalized states versus medicalized states that the practitioner intervention actually opens up access to a lot more disease states. And that's largely just due to patient education. A lot of patients, think cannabis for nausea, for cancer, for pain. They may not necessarily think, irritable bowel syndrome, multiple sclerosis, Parkinson's disease. Cannabis isn't the first thing that pops into their head. And so that practitioner intervention really opens up a lot more disease states and applications for patients to have access and even know that medical cannabis may be of benefit to them. So typically when a patient goes to a practitioner is looking for medical cannabis, obviously a practitioner can always just say, no, I want no part of this. I'm not going to recommend it. I'm not going to talk to you about it. You're going to have to go somewhere else. And that happens far more often than we would like. It's really unfortunate because it only helps perpetuate the stigma around cannabis. But if they don't say no, we usually see one of four things. So the first, which is the ideal approach, is collaborative care, where the doctor has done their due diligence. They're sending the patient to a dispensary that has a pharmacist. So it's a true pharmacist-patient practitioner collaboration to really evaluate their needs and help guide them in what sort of ratio, varietal, dosing of cannabis is going to be a good starting point for them and educate them on how to self-titrate. So that's sort of the ideal scenario. Often we still see practitioners who tell patients just go buy it on the illicit market. They don't want to get involved. So just go buy it, it'll help you, which sort of takes out the idea of, a safe, regulated, tested product to make sure there aren't any contaminants or excipients or other illicit drugs in the cannabis. It also puts patients at risk for not having standardized dosage form. When you go to the dispensary, you can typically get the same thing every time. That's usually not the case with the dealer. And it definitely puts the patient at risk. But we do see a lot of doctors who say, just go talk to your kids or talk to your neighbor. You can find it somewhere. The other option is to say, okay, I'm going to recommend cannabis for you, but I don't really know anything about it. Just talk to the dispensary staff. They can help you. Which, in the 5 states that have pharmacists in the dispensary, of which, I'm part of one, that works because they're still getting clinical oversight. But by and large, we're looking at dispensary staff who are just really educated on cannabis and not necessarily on anything else. So that also can be a risk for the patient. And then finally, what we'll also see is they'll say, well, don't worry about medical cannabis, just buy hemp CBD. CBD is the medicinal component anyway. You don't need the THC. That's just for a euphoric effect. That's just for people who want to get stoned. By the way, I'm selling hemp CBD in my office. Just buy this and you'll be fine. And I sort of went into a lot of detail on hemp CBD on my last presentation. So I'm not going to belabor that point here, but definitely that can be a disservice to the patient as far as their expectations of what they can get out of hemp CBD and how it should be dosed as well. So going a little bit more in depth as to the dispensary process, as I said, ideally it's a collaborative process where the doctor plays an active role in not only making sure patients are good candidates for cannabis, but they also evaluate dispensaries and make sure that the dispensaries they're sending their patients to are doing a proper job of evaluating them and making recommendations to them. The dispensary themselves may or may not include pharmacist oversight. They're often recreationally focused and lack formal clinical training, and their recommendations are largely based on anecdotal evidence. And again, we don't have a lot else to go on other than anecdotal evidence. As pharmacists, we use the research that's available and our underlying clinical knowledge to be able to make the best recommendations for a patient and to sort of guide them in the process. But in a lot of dispensaries, that doesn't exist. So you can know a lot about cannabis, but that doesn't mean you sort of have that underlying advanced medical degree that's going to allow you to properly evaluate a patient, to know if they're at risk for arrhythmia, if they have other underlying medications or disease states, to be able to perform medication therapy management, to taper them off of duplicate therapies as they're increasing their cannabis use. A lot of that doesn't necessarily happen without clinician oversight, especially if the doctor themselves aren't sort of well-versed and well-educated in cannabis as medicine. And then we also have the patient with their preconceived notions and armchair experts. If they've read a lot of sort of website topics and things of that nature, they tend to think that they know everything there is to know when they may not necessarily. And so, there's a lot of intervention. So obviously there are three main barriers: lack of accredited practitioner and dispensary staff education, which my team is working on. We have an accredited program coming out within the next month, so we're really excited about that. The lack of clinical oversight in the dispensaries, and then obviously important for this topic is the lack of reliable controlled research to guide clinician decisions. And so as far as research opportunities, we need to look at research that's formulation specific or comparison focused. We need to look at research that's using products that are actually available to patients. We need to do translational research in partnership with practitioners, dispensaries, and state medical marijuana programs. In most states, all medical cannabis purchases go into the prescription monitoring program. That's a wealth of information of qualifying conditions, what patients are using, that could be accessed and used to give some really good data in order to see what patients are using for specific dosage forms, what formulations are most commonly purchased. And that all of that information is really just sitting there. No one's really utilizing it appropriately. And that's, to me, the most fascinating area where we could be doing more research, because the data is there. We just need to mine it. And we'd have some really, really powerful information, I think, for clinicians and for patients and dispensaries moving forward. And then finally, we do need some baseline endocannabinoid system testing to better predict patient needs, so that in the dispensary we have some good baseline information of where the patient needs supplementation most, and where we can sort of intervene in a way that's going to be most successful for them.
I so appreciate it. Dr. Woodcock, if I could ask you a couple of questions I see on the chat Q&A, I'll try to weave them in here. As far as precise dose, and patient preference, what would you say that patients are really, the forms that they're consuming, right or wrong or optimal or not?
It's interesting because most patients come in thinking they want inhalation because it works the fastest, but a lot of them have chronic issues and they need more long-term therapy. And so we usually guide them towards a tincture. A capsule is sort of a maintenance, more longer lasting dosage form, and save the inhalation for intermittent breakthrough pain, breakthrough symptoms, panic attacks, things that actually need that immediate onset, like PTSD, things like that. Patients don't really understand that there are nuances between inhalation, sublingual, and oral dosage forms, not just in the onset and duration, but in the actual chemistry. When you ingest cannabis, more of it is metabolized into delta-11 THC, which is more psychoactive. It crosses the blood-brain barrier more readily. So there are definitely nuances in the biochemistry that patients don't understand. that we have to guide them on. But, I think that most commonly we see the CBD tinctures and vapes for anxiety. We see 1-to-1 for inflammatory disorders like multiple sclerosis, fibromyalgia, and then the high THC for patients trying to get off of opioids for chronic pain. And even sometimes for anxiety as well. It's really interesting because THC has that biphasic effect, but some patients don't respond to CBD and they respond to THC. Some patients, the THC exacerbates their anxiety and we have to go more CBD. And so I think one of the things for me as a pharmacist that I love so much about cannabis, and I think Dr. Sisley said the same thing, is that it's patient-led. They're titrating their own dose. They're deciding what works for them. And most of the patients that come into the dispensary are refractory. They've tried everything. Medicine has been throwing drugs at them, and they have no control over what's happening to their bodies. And so giving them a medicine that they have control over is really powerful as far as just their mental state and fortitude and giving them some control back of their life. And I think that people discount that as being as powerful as it is when it comes to cannabis medication, but it's something we see every day that's been really, really powerful.
And do you have any last moment predictions into the next few years for other dosing forms just rising in popularity that you expect?
I think patches are really rising in popularity, especially as nano dosing forms and ways to sort of cross the skin barrier and get into the bloodstream more efficaciously are being developed in a really successful way. So I definitely think that's coming. I know that the food and beverage industry is bustling. As a clinician, that's not my favorite thing to see necessarily, but it's definitely on the horizon for sure.
Well, Dr. Stacia Woodcock, we so appreciate your expertise and the work you do, and for you sharing the information today on the Global Cannabis Research Summit.